pleasure to be here. Thanks to Hugh and the rest of the Cirdan group. Cirdan, as you probably know, is one of the jewels of the crown of our biomedical and scientific industry in Northern Ireland. So obviously, it's a pleasure. It's a pleasure to be here. My task is to talk to you about personalized medicine and the future of tissue pathology. And I normally do this in a lecture that is already prepared, but I thought that after 4.5 years having dealt with the molecular pathology program that Peter and I started, I thought it would be probably more useful for you if I were to present this in a slightly different way. So I'm going to take you through the program since we started it and all the decisions that we took based on where we think the future of tissue pathology is going to go, and hopefully try to illustrate where we think the area is going. So it all started when I joined Queen's in 2011. I must say that working with Peter, with Jackie, with Stephen McQuaid, and with Perry Maxwell has been one of the greatest joys of my career. Obviously, when I arrived in Queen's already had one of the most advanced digital pathology programs in the UK. Jackie James have already constructed what it is a wonderful biobank, and Stephen and Perry are two very senior and very experienced clinical scientists. Where were we in tissue pathology back in 2011? Allow me to take you through a paper that we wrote in 2007 to start thinking where we were. Remember, pathology during many centuries was the pathology of the dead. We used to look at histology and particularly anatomy to learn the physiopathology of diseases. And sometime in the 1950s or 1960s, a revolution came. So pathology became clinical. In fact, in the 1970s, 1980s, pathology was the center of the activity in many academic hospitals. So much so that even today, no oncologist, no surgeon, no physician would decide on therapeutic intervention unless there is a very specific histopathological or anatomical pathological report. And this was extraordinary for the area of pathology. The problem is that in parallel to that, we started learning more about the molecular basis of disease. The anatomical and clinical dimension of pathology develop a molecular dimension of pathology as well. And this obviously has been challenging the area for a while. It has definitely in the area of research. So this is from 1999, the then director of the National Cancer Institute, challenging the scientific community to harness the power of comprehensive molecular analysis technologies. And look at the challenge. The challenge is very clear. Is essentially to change the basis of tumor classification to morphological to molecular. And that has had an extraordinary translation in the way we are doing diagnostics as well. We know, for instance, that in colorectal cancer, we have many molecular tests based on tissues that are very specific in decided on therapeutic intervention, and some of those already have very clear international guidelines. We know that in breast cancer that has been happening for a while, and not only talking about ER, PR, and CHRV2, but other markers that are in clinical trials, and we are beginning to see very specific mutations that probably can allow us to make decisions on breast cancer treatment in approximately 10% of the patients. It's happening in the big paradigm, which is lung adenocarcinoma, where more than half of the cases can be now classified by very specific mutations or abnormalities that are druggable or potentially druggable. And again, there are international guidelines for that. We know that it's happening in sarcomas and lymphomas, where we are looking primarily at sarcoma translocations, because we know that each translocation is pathognomonic of a very specific disease with a very specific diagnosis and a very specific treatment. It's happening in malignant melanoma, as you know very well here in Australia. It's happening in glial tumors. Again, essential according to WHO to understand what's the molecular basis. In fact, what is happening is that there is a revolution in oncology that is affecting the way we practice pathology. What oncologists have now is many antibodies and small molecule inhibitors targeting very specific genes and pathways. When I reviewed this in 2012, there were, or I counted, approximately 16 of such tests associated with drugs. 2 years later, in a review that Peter shared with me, that is already approximately 32. This is the way the area is moving extremely fast. And what is happening, obviously, is that we are putting a level of molecular complexity between our morphological analysis and the treatment and the decision making. Even in 2007, when most of these tests were not available, you could see that that existed, including, obviously, multiple biomarker analysis and the promise of pharmacogenomics. And this is what worried some of us, the fact that, according to a previous president of the College of American Pathologists that kindly used this material, the future of the value of translational pathology has not diminished, it is simply not longer sufficient. And the idea, obviously, is that if we want to remain at the center of therapeutic decision-making, pathologists, pathology departments should start doing, why not, these single tests and also the multiple tests that we think are going to be very important in the future. So from March 2011, we moved to September, where as a group we decided what was going to be the focus of our molecular pathology program. We are talking about an integrated focus, an integrated program, and by the way, you can now read about it both in Molecular Oncology and 2 or 3 days ago in this paper in Drug Discovery Today. What does an integrated program in molecular pathology mean? Well, think about it. When we are doing diagnostics, we are using clinical samples, we are using the best possible technology, we are using the best possible manpower. When we are doing translational research, we are referring to exactly the same samples, we are referring to 80% of the same technology, and we need the same technical know-how to apply it. And remember, more and more, if we do research, we need to do it with high quality. Why? Because that is the research that is going to be FDA approved in the future. Similarly, diagnostics needs a complexity in technology that healthcare seldom can afford, and it can be afforded by academic environments. Therefore, we decided to put both in a single laboratory. And that is a laboratory that, as you can see, puts together all the pieces of the puzzle. Biobanking, traditional pathology review, hybridization methods, single and high throughput PCR technologies, digital pathology and information management. All that under a single umbrella. As you can see, accredited by CPA and following QA/QCs so that we can attend to the needs of molecular diagnostics of healthcare today, but at the same time with a significant research funding associated with it so that we can also do discovery and support the discovery that others are doing. So by March 2012, the Northern Ireland Molecular Pathology Laboratory became fully operational. Fully operational meaning that we have the menu of single tests that were basic for us to start serving the Northern Ireland population with cancer, and at the same time to have all the capacity that is necessary to move translational research forward from a pathological point of view. Molecular diagnostics in the context of clinical trials, analysis of tissues ahead of molecular analysis, tissue biobanking, all the different forms of pathology, informatics and digital pathology, data management, biomarker validation, and integration of validated biomarkers into routine diagnostics. What we want to do in that research space is to solve a big problem that Scott Kern showed very neatly in this paper. The vast majority of the biomarkers that we are using today will never make it into the clinic. Never. And the reasons are varied, but the bulk of that reason is essentially because we are not designing and carrying out those biomarker analysis well. In other words, there is what we call reality filters that make the vast majority of the biomarkers not being useful in routine. And we need to change that. And later on, I'm going to show you the model that we've put in place that hopefully will be able to tackle that. So from March 2012, we started publishing in the areas that we thought were relevant for molecular pathology. I'm just going to show you a few. This is all the technology that we have in the laboratory today. The idea here is to show you that this is all integrated, but also that, as you can see, we have a very broad definition of what molecular pathology means. Not only we are talking about next generation or high throughput gene expression, as you can see, tissue preparation, tissue analysis, automated immunohistochemistry, ahead of imaging, scanning, and digital pathology is molecular pathology. Why? Because immunohistochemistry is molecular pathology. In this paper, we try to show that there were probably 3 types of immunohistochemistry, and what we call today therapeutic immunohistochemistry, the histochemistry that we don't use as pathologists to decide if something is carcinoma or sarcoma, but something very specific, with a very specific result that is going to decide on therapeutic intervention. That kind of immunohistochemistry probably belongs to the molecular pathology environment. So much so that we think that the validations of that immunohistochemistry should be very different. And what we have proposed is a probably rather complex way of validating antibodies in immunohistochemistry, but that you can actually condense in 2 main principles. The validation needs to represent the right biology of the biomarker, and the validation needs to be measured against established diagnostic gold standards. Definitely in the immunohistochemistry that is clinical, that is genetic, or that is therapeutic. And that also applies to digital pathology and molecular diagnostics. And Peter may have shown this before. Definitely there is a digital pathology that is molecular in the scoring of those biomarkers that I mentioned earlier on, but also, as Peter showed earlier on, in the preparation of samples ahead of DNA and RNA testing. This pre-analytical process is classic morphology and is going to determine the quality of the molecular test down the road. And it's a very, very important context. And the other thing as well that we're beginning to learn is that sometimes immunohistochemistry may not be the best way of looking at digital pathology in tissues. This is something, again, that is just in press. We are using something called RNA scope, an mRNA technique to detect the expression of some biomarkers. We use P10, which is a biomarker that is notoriously difficult by immunohistochemistry. We validated, as we mentioned earlier on, with cell lines, first of all, comparing protein expression with gene amplification, etc., showing the concordance and the discordance between the different levels in the biology dogma, and very interestingly, applying something that is highly quantitative, but also that is highly focal. We can go into a gland level and start measuring heterogeneity, and that gland level, that for those scientists now that are beginning to understand the value of heterogeneity and how that can affect the clinical endpoints, is obviously very, very important. So in January 2013, we got our accreditation that confirmed that we can do molecular testing in patients. This is important for us for 2 reasons. We do CPA and UK NIQUAS not only to show our hospital that we are competent to do this test, but also to show research agencies and charities that we can perform research according to the best standards, and to show industrial quality. It's a badge, if you want, of quality beyond what is only diagnostics. And if you look at the amount of funding that our lab has directly brought into the center or has significantly supported, we are very, very convinced that this is because of the fact that we have linked diagnostic quality to research output. So in January 2014, we had our first example of how the laboratory could link with industry, and this was with one of our regional companies, Almac Diagnostics, and the DDRD test. DDRD stands for DNA Damage Response Deficiency Assay. This is an assay that applied to ovarian cancer, to apply to breast cancer, can predict what is going to be the response of a patient to chemotherapy. And the main paper was a paper in which we were very much involved. As you can see here, in cases where there has been chemotherapy, DDRD negative or positive, it doesn't matter. In cases with no chemotherapy, where chemotherapy has happened, as you can see, the DDRD signature has a very strong prognostic stroke predictive value. And this is now in the market for several cancer types. From January 14, we continue working on our publications. Allow me to show you some that are relevant to other aspects or other technical aspects of molecular pathology that I think are going to be very important for the future. Next generation sequencing. Remember what's happening with next generation sequencing. Sequencing is becoming faster. Sequencing is becoming broader. We are taking more aspects of the genome. Sequencing is becoming cheaper as well. In the research paradigm, next generation sequencing is relatively clear. We use clinical samples. Usually we choose the ones that are of the best quality. We analyze them, usually with a discovery NGS, usually a very broad design of next generation sequencing. We confirm selected findings, usually with orthogonal methods, Sanger sequencing, Paro sequencing, etc. And we are very selective in the results that we report. This is one example of something that we've done very recently. This is one of those cancers of unmet needs, small bowel cancer, where you can see we found new mutations, many of them not discovered to date, including, for instance, mutations in the HER2 gene that were associated with amplification, overexpression of the protein. So very clear novel targets for cancers that we could not detect yet. And that led also to the analysis of further proteins and other possible prognostic markers as well. Now, we know that the genes that carry mutations in cancer that may have biological implications are finite. In fact, some people would argue that we are talking about 140 genes, at most 12 signaling pathways. So because of that, if we are applying this to diagnostics, the paradigm is different. It's different, first of all, because we cannot choose the sample type. In diagnostics, we have to analyze whatever comes through the door. The NGS analysis is probably more targeted because it's easier to validate that broad NGS approaches. We don't want to confirm the results with orthogonal methods because that would make the test prohibitively expensive. And we need to make sure that we can report as much as we have in those results that are clinically meaningful for the patient. And we started working on this, first of all, to make sure that we could trust the technique. So this is, or the technology. This is our first validation, one of the first validations published, trying to see if we could trust NGS in the mutations that were clinically relevant. So what we took were cases with classic mutations, 2 different platforms, 5 different bioinformatic analyses, and the question is, okay, can I trust what I'm going to use today to decide on therapeutic intervention today? Can I trust my EGFR results in lung, my BRAF results in melanoma? And the other question is, can we trust the other information of the other genes that may be relevant, for instance, for clinical trials? And the answer to this study was yes. So we moved together with our colleagues in the Marsden to start indicating what was the characteristics that a validation should have to make sure that that validation was clinically meaningful. And in fact, I can show you at the moment validations in what were the preparations for our first big clinical trial. This clinical trial is Mercuric. It's a €6 million clinical trial centered and led by Belfast. We had to validate, as you can see, a next generation sequencing approach of 10 genes with all coding exons in each of the genes. We made sure, obviously, that the coverage of the design of the NGS was there. We made sure that we knew the areas of weakness in that design. Almost every NGS design has weaknesses, and if they don't tell you, ask them for it, because that will be very important when you're going to interpret results. You have to make sure that your isoforms are represented, and then what you end up after the validation is with a pathway that you can start using in the clinical trial context. I throw this image, I know it's very busy, but to tell you something that I think is extraordinary. So here you have the same samples analyzed by two different NGS methods. This is an ion torrent, this is a multiplicon analysis. And see how extraordinary this is. Not only the mutations were actually there, the allele frequency had differences of 3, 4, 5%. Extraordinary. Two different machines, two different designs, and look at the concordance. I think this technology is moving to a model in which we may not need downstream validations to use it in routine. In fact, the question now is not so much do we test, the question is how broad do we want our testing to be? And this is our own definition of how you want to test. You may want to just test what our NHS can afford today, which is what is the immediate actionable mutations. It may be that you want to use, you may be in a clinical trial environment, all the mutations that are relevant for that particular cancer. You may want to use a comprehensive analysis for all the cancers, or you may want to have the most comprehensive human cancer analysis that you can detect. And of course, the use will probably indicate how broad your design is going to be. If you are on pure diagnostics and your government is going to pay for it, probably you're going to be very close to class 1. And related to this is something that may interest some people in the audience, and is that at the end of the day, I'm spending today much more time analyzing the results than generating the results. And generating clinically meaningful results in NGS is extremely difficult. Why? Because at the end of the day, once you have generated all the results, your variants are there, they are very clear, they are unequivocal. Then the question is, what is the clinical meaning of that? Is a mutation activating or inactivating? Is the mutation leading to sensitivity to a specific target or not? If you have several mutations that are actionable, how do they rank from a therapeutic point of view? In fact, the more we look at it, the more we realize that today we are actually managing levels of genomic uncertainty when we are doing this kind of analysis. And in fact, this is the way some people manage that genomic uncertainty. There are results that are very clear, that we know what they mean, that are known in the literature, there are clinical trials supporting it, and we can give a clear indication that the patient should be treated. There are others that we don't have a clue what they mean. And then there are different levels of certainty in between. And in fact, some people, when they start reporting this next generation sequencing, they're actually color coding the level of uncertainty or certainty based on how do they see that that is relevant in the literature. So, more examples of industry. I arrived late but early enough to realize that Peter and I are probably going to explain you the same thing from a slightly different points of view. TissueMark is the other product in which our lab has been heavily involved. We believe that the only way that we are going to be successful applying all this technology is actually by having a very strong pre-analytical analysis of that material. What is the percentage of tumor cells and the total number of cells in a sample is critical. And by the way, as pathologists, we are useless to indicate this from an objective point of view. This is from our own internal PathXL QUB assessment. Breast cancer, 3 pathologies, the results are everywhere. And this is not because Northern Ireland pathologies are particularly bad. If you look at published work, the same has been shown in lung cancer, the same has been shown in colon cancer. What this paper is trying to show is that there is an automated way of doing it, which Peter has already presented very, very eloquently. The interesting thing here is that when we repeated the molecular test based with the annotation that was done by tissue mark, the results were exactly the same. In fact, what we are beginning to see now, at least in the UK, is an extraordinary interest from Genomics England, from UK NIQUAS, to start applying this pre-analytical analysis to make sure that the results with whole genome sequencing or with other material, other technology are accurate. And we are in the process of creating a very specific program for UK NIQUAS that we hope is going to start working in January exactly for that purpose. We took teaching very, very seriously. And we took teaching very seriously because it was very obvious to us that while other disciplines in pathology were moving into a strong molecular component, histopathologists were not. And what we have done is essentially to indicate how we have changed the college curriculum to make sure that our trainees in pathologies get that kind of exposure. By reporting with us the cases that we are reporting routinely, by giving them different options during their training of when they can come to our laboratory and learn molecular diagnostics. Some of these are optional, but some of these are mandatory. By mapping what it is that they should learn and put it in a booklet so that the 2 or 3 months that they are with us, they learn what we think is the basis for tissue molecular diagnostics, and giving them further expertise for those that want to spend a year with us and become bona fide tissue molecular diagnosticians. In January 2015, we had the renewal of the Northern Ireland Biobank. Credit to Jackie James. Extraordinary biobank, which is at the moment collecting all frozen, or much of the frozen tissues, is governing all our retrospective paraffin-embedded collection, and is, as you can see as well, governing all the leftover DNA and RNAs that we have from our molecular diagnostic work. More than 150 projects cutting from international, national, industry have come through that biobank in the course of the last 4.5 years. 2015 has been a good year for us. We got CR UK Accelerator Award. This is essentially a £3.9 million trying to make sure that all the centers that are part of this Accelerator Award speak the same language from the point of view of digital pathology, and also trying to move cancer immunology forward. I think that cancer immunology and cancer immunotherapy is one of those areas where I think the future is going to come. Since the early work of Jérôme Gallon, we know that the detection of very specific inflammatory subpopulations have very clear prognostic implications. With one proviso that makes it particularly important for us, for tissue pathologists, it is what he calls the immune contexture. is not only which inflammatory cells are present, are also where are they present in the topography of the tumor that makes the difference. And I cannot see how we are going to deal with this mess if it is not with very sophisticated digital pathology approaches. And what Peter and I are trying to do now is to start, and this is a program that I only started 2 or 3 months ago, start looking at the expression of these biomarkers and again the immune contexture to produce that zonation that would allow us to get the best possible information from those biomarkers. The other component that I think is very important is the detection and the targeting of immune checkpoints. Remember, what are we doing today with what we call classic genomic targeted therapy? We are actually buying months, perhaps 1 year of life from many of our patients. The patients recur and many of them eventually die. What we are doing with immune checkpoints is actually making sure that a percentage of the population, probably not as big as this diagram is indicating, have very long-lasting survivals to a level that we've never seen before in malignant melanoma, in lung cancer. And the idea is that maybe combining both, that is going to go, that is going to improve. This is, again, some of our work with one specific cancer type, where, as you can see, there is a lot of hypermethylation. There is obviously very high MSI, a very interesting and a specific mutation pattern. And here you see the relation between microsatellite instability and the expression of one of those immune checkpoints, PD-L1. Now, PD-L1 is one of those biomarkers that we are all trying to score, that we are having significant difficulties with, and again, where subcellular localization and topographic localization are going to be very, very important. And it matters, because if you see the correlation of our different scoring modes with the instability status, different expression patterns are associated with a different biology. So it is very important. And what we are doing now with this program is moving systematically to find digital pathology solutions to score most of these cancer immunotherapy markers that I think are going to be very, very important. Very good news last month. Our service has finally been commissioned. A regional, fully commissioned service, which for us is very important. Most molecular diagnostic services in the UK are not commissioned. They are paid by pockets of funding that come from other areas of the NHS. So again, the fact that this is happening now in Northern Ireland gives us the opportunity to start moving forward in a very systematic way. At the moment, our laboratory is covering or offering testing to the vast majority of the hospitals in Northern Ireland. We are covering approximately 85% of the territory, and we hope that this will be 100% very, very, very soon. And the other thing that has happened, that has come to our door, is Precision Medicine Catapult, with an I. I'm sorry about that. Catapult is essentially a national program that is putting funding, or programs that are putting funding to link academia and industry and make sure that the industry fabric of the UK gets improved in the process. And just 6 days ago, it was clearly announced that there's going to be 6 centres of excellence in the UK, including Belfast. Our Centre of Excellence is going to be very much focused in molecular pathology. To deal, for instance, with problems like this, if you look at the amount of academic papers in biotech per £1 million in public funding, and you compare what we are doing today in the UK with what we are doing, for instance, or what it's done in the Boston and California areas of the US, the originality and the output of the UK is higher. But if you look at the amount of venture capital investment that comes associated with that discovery is extremely small. And this needs to change. The way we would like to change that is by beefing up our laboratory to make this process happening. A process in which you take biomarkers coming from wherever they are, where we give a preliminary analysis of how good they may be, where we have a very specific assessment of how good that biomarker is from all points of view, economic, financial, diagnostic, scientific, and to start designing a pathway of commercialization that then will come to our laboratory and will finalize that kind of analysis. Because think about it, what is happening at the end of the day? We are all saying that you need to have this as a link, that you need to move from preclinical to industry. And I wish it was as easy as that. It never is. Why? First of all, because it's not only academia. You need to bring healthcare, because most of the questions that we are trying to answer come from healthcare, and many of the things that we need to answer require information and materials that come from healthcare. It's more complex. Why? Because sometimes academia is not only involved in preclinical research, it's already involved in early stages of product or technology development. And it's important as well, because even if you do this in the best possible way, if that product doesn't come back to have a clear plan for adoption in the NHS, there's not going to be a way that industry is going to be able to move that product. In fact, at the end of the day, I don't think this is a line. I think that this is a circle. This is a circle in which clinical and preclinical research, product technology and development by industry, and adoption back into the NHS should be part of a single development. So, where is the future going to take us? Well, I hope I've given you some clues of where that could take us. Personally, it's going to take us to move into a new building, because the activity that we are having is too big for the laboratory that we currently have. So we all welcome you to come to see us, hopefully in February or March, to this building, where we are going to take 3 floors, a basement for biobanking, a first floor for bioinformatics, digital pathology, and some offices, a first floor where we are going to have the whole consolidated laboratory, as I mentioned earlier on, and this is then complemented by the program on biomarker discovery and targeted drug discovery that we have in Queens as well. I think the future comes through integration. Integration of tissue pathology with molecular pathology, of technology platforms, IT systems, and materials and clinical information, integration of talent through training, integration of diagnostics and research through common resources, through common laboratories, integration of healthcare, academia, and industry, always through quality. In fact, as I was in the plane, I was thinking, maybe we are already mature enough in Northern Ireland to move from the paradigm of individual projects supporting industry and start bringing big consolidated programs. We have the talent and we are beginning to have the funding to make it happen. For instance, we have a single health and social care. We have a single regional molecular pathology diagnostic service. We have 5 tissue pathology services, soon maybe 4. We have Cirdan as a leader in IT, in LIMS systems. We have Sectra linking already all these hospitals through imaging in radiology. We have PathXL, one of our leaders in digital pathology. And we have Invest Northern Ireland and now Catapult, very happy to start pushing some of these groups forward. Maybe we are ready. Maybe we should have a single integrated holistic information and diagnostic imaging system for Northern Ireland that will help the patients, that will help science, and that will help all the industry partners to start bringing their products as an alpha or beta testing and start moving those projects forward. I think we're ready for it. So allow me to thank the group and the people that are funding our laboratory. Allow me to insist that working with Peter, with Jackie, with Stephen and with Perry has been one of the greatest joys of my career. And remember to, allow me to remind you that Northern Ireland is not a place that is characterized by the sun, but there are a lot of sun in people's hearts. And if you think that you haven't had enough digital pathology or pathology today, if you want to join us in June 2017, we're organizing the meeting of PathSoc, and there will be a lot to discuss on digital pathology and other higher aspects of pathology and maybe another higher aspects of life. Thank you very much.